So, Peter, thank you so much for coming on the Ray Summit to talk about your technology. AI is really going to be changing medicine in the next 5 years, and everything that was seen there from Peter is really really an open window to showing some of the transformative technology that's actually coming our way. What we want to be able to do is show a little bit of our journey going from AI to the bedside, building web applications that actually meet patients over in the community, and show how we've actually been scaling the technology of machine learning using the Ray API as a transformative reinforcement learning algorithm that has done three major advantages. One is being able to use that technology to inspire interest from the community, bringing people that love machine learning to build this type of technology. And secondly, open the doors to advancing the number of machines that can be used. And thirdly, also bring people like myself and Peter that work in healthcare to battle these problems in using this technology in machine learning. The major aspect and the difficultness of healthcare is really the large amount of data that exists in healthcare. The complexity of the disease types that patients have to go through is usually quite complicated, going through multiple different avenues to be able to figure out how to treat these patients. Not to mention actually moving sometimes in multiple different software planes to be able to get the data. And because the disease is usually very complicated, it creates a scenario where there's a tremendous burden usually on the physicians to be able to navigate this data and synthesize this data to be able to treat the patients. And what we've learned is that a lot of the machine learning algorithms, because of the ability to bring action and bring knowledge to the point of care for the physician, we believe that this technology is really going to reduce the burden of the physician over time, increase our speed, increase our impact, and increase the reach of the number of patients that we need to treat. As we were developing the technology, we noticed several incredible aspects of the technology. One is that many of the modalities in healthcare, whether it's EKG technology, like Peter is talking about, ultrasound, radiology, much of the technology gets transformed into natural language. And there are major reasons for that. In the very beginning, the technology was very difficult to find. You had to require different logins and different softwares just to get access to the EKG. And sometimes the radiological data was not available. The second aspect is that the expertise that's required to interpret the EKGs, as you've seen, is highly specialized. And in radiology, even more so, such as CTs of the chest and the abdomen, and CT of the brain, and MRIs of the brain. And so the radiologist brings with them a tremendous amount of experience to be able to turn that into something that is very actionable, knowledge that is actually very usable for any of the people and the member of the care team that Peter has talked about to be able to act on the patient and treat the patient. It turns out that the diagnosis that these modalities bring enormous amount of benefits to the patient, because you're able to classify the patient in a way that really structures and streamlines the treatment paradigm and give standard of care treatment for the patients and advance their health and advance their quality of life. But because every modality dumps into the natural language space, when we use natural language, we are now able to actually connect with every corner of the healthcare system and be able to glean data from that. And when we were doing that and built some of our supervised learning type models to recognize those unique actions that doctors do, we actually realized something. One of the greatest innovators that brought really important products that have changed the lives of lots of individuals in the world, we marked exactly how far in the future he actually was. And this is one of his quotes. If we can come up with machines that capture the underlying spirit of an individual, we can potentially capture the worldview of these great people, these leaders. And one of the heroes that he talked about was actually Aristotle. And what he really meant was not just Aristotle to be able to have students ask Aristotle's questions through a machine, but to be able to capture the Aristotles of our generation and have students be able to ask them questions and have not only just a book, but the ability for students to interact with that knowledge in an incredibly meaningful way and potentially over and over again, and to be able to scale out to lots of different people. And we've made that realization as well. As we started to use medical record systems from our electronic medical records, we were training models with millions of data points and be able to bring up diagnosis and be able to validate those diagnoses. what we realized was that the machine was bringing us the diagnosis of patients very similar to how Peter was doing it on his. And that created for us a very unique opportunity. Not only are we able to capture incredible physicians that are able to treat patients with really high quality medications and medicines, but we're actually able to capture people that have inspired our lives as well. So one of the incredible heroes of my lifetime that brought me into medicine was Albert Einstein. His persistence, his creativity, his out-of-the-box thinking was truly inspiring. And I studied that all through my youth. The ability to bring his knowledge and his characteristics into medicine would potentially be incredibly beneficial for healthcare. And with that type of technology, we began to actually build our first web application, a web application that touched base on patients and allowed physicians to supervise the algorithms themselves. We knew that during COVID-19, very, very early on, there was not a lot of data available to answer patients' questions, but we knew that the physician was the closest individual to the sciences to be able to deliver those answers and correctly guide patients. We used a machine that actually took in a Latin natural language and be able to start to incorporate the intuition and the choices of physicians into these algorithms. That allowed us to be able to capture a huge knowledge base with questions and answers asked by patients, and be able to deliver the answers just as physicians would do. And our physicians came from all over the world, from across the United States and also from different parts of the world as well, such as India. Our first project was known as ASCO 19, and we began to advance on that concept. We wanted to go beyond just a question and answer algorithm. We wanted to be able to inject more knowledge into the algorithms themselves. And then we began to bring the knowledge of the electronic medical records and the workflow of how physicians actually treat patients. We realized that the workflow of how physicians treat patients offer a very natural fit for reinforcement learning. It turns out that physicians formulate a hypothesis first and then begin to test that hypothesis logically by asking for labs, EKGs, imaging, and prove that out in a very sequential format. A lot of the medical literature that we have now is usually a display of correlation of one single treatment or intervention and how well the patients do over time. But in reality, in clinical practice, the physician actually performs multiple number of different interventions before they're actually able to get the patients to turn out right. Reinforcement learning learns in a very unique style of understanding the different sequences of events that actually occur and take that knowledge in and build upon the reward system and follow the trajectory of the best reward system that we can. So once we developed the original knowledge base from all of the data that was available in the system, we were then able to actually take a platform, one of the specialized APIs of the Ray library, to incorporate that knowledge base and bring the actions that it recommends to the physicians and allow the physicians in local practice to be able to fine-tune that body of knowledge to the current environment that they're practicing in and allow us to practice at a very high level, both with an interaction between the machines and the physicians themselves. This is an example of how the physician write-up usually is. And it turns out the physician write-up is a very pattern type system, very concise and very precise. It is written the same way almost every single time, but it incorporates very advanced level training and education. A medical student would train about 4 years to get to this level and then practice for 3 to 4 more years and potentially subspecialize with an additional 2 or 3 years to be able to get this language right so that you capture the exact presentation of why the patient presented with their illness. And with that, you're usually able to capture the exact reason in the diagnosis within the first sentence. And within a glimpse of an eye, you have the diagnosis. And just as our algorithms, just as humans are able to decipher this particular praise, we're able to see that this 69-year-old male with a history of tobacco abuse and diabetes is presenting with a cardiac problem, typically with obstructive angina, coronary artery disease. And the prose in the vignette actually goes on to describe the sequence of events, the data that is collected on EKG with the ST elevations, and also with the non-ST elevation, with the non-sustained ventricular tachycardia that is actually given here. Our algorithm was able to pick up on pretty much every diagnosis that was actually provided here without having us to train it with the exact definition of NSVT. It was able to actually pick out the code for the ventricular tachycardia. And the reason why it chose that as the first diagnosis to pick up was because ventricular tachycardia is usually the most concerning diagnosis in a patient that presents with obstructive coronary artery disease. And in this particular way, we trained all of our diagnosis and pushed the data type until we were able to obtain relatively reasonable AUC scores, and we pushed higher and higher. As we added more data to the system, we were able to train the algorithms for a particular diagnosis and get it performing better. Each of the models that we built in there acted as a stepping stone and a building block for what's bigger to come. The reinforcement learning algorithms take those hard-coded real-world action types, such as diagnosis, treatment with medications, order entry, as well as laboratory orders, and allows it to collect the feedback from the environment, and that is the patient response, the physician acceptance of the particular order, and what actually goes on in the entire environment of clinical practice, from the nursing staff all the way to the actual outcome of the patient. This particular example with Alphago truly captured the hearts and minds of physicians and really started to allow physicians to understand how far they can go with algorithms today. Alphago, in the game of Go, where there are more atoms, where there are more board positions than the number of atoms in the universe, is very likened to the complexity of medicine, where medicine is practiced all the way down to the biochemical levels. If we're able to capture that large of a space, then potentially we're able to actually practice medicine as well with these incredibly sophisticated algorithms. And it becomes paradoxical in a way. So as we design these UI, UX interfaces for the physicians to be able to interact with the data, what we realize is that in order to make the burden of the physicians better, improve the speed and the quality of workflow, and allow the physicians to really enjoy what they're actually doing, we actually have to build incredibly sophisticated algorithms to do that. And in this particular way, we took an inspiration from one of the sort of ultimately incredible products out there with autonomous driving and the HydroNet from Tesla, and we built our own version of HydroNet where we had multiple outputs, including diagnosis, treatments and labs, and even COVID-19, to go upon a shared backbone and have the reinforcement learning algorithms take those outputs and recommendations and begin to receive the feedback from the environment to be able to optimize for the trajectory. And in fact, not only do we have a limited number of models and outputs, each of these models represent a particular detector that we have trained. We can potentially add more and more models with the Ray API, integrating all of those models together to provide a much higher and more specific treatment plan as we include that. And in fact, even Peter's model can potentially be added in there because in the medical records, the EKGs actually already exist. And we see that using temporal difference learning, this system itself does what, in addition to fine-tuning itself to the rewards, it actually adds the capability to be able to predict how well it does and then subsequently proving itself out in actually the real practice using a TD style type algorithm and improving the entire environment in which the algorithm belongs to. And this is really the ability for reinforcement learning to actually bootstrap the data that it gets. It changes the recommendations and changes the way the physician actually picks the patients and potentially improves the type of patients that it picks for each diagnosis and each treatment. And with that, we continue to improve on our algorithms to obtain better and better diagnosis from the patients that it sees, improves the way the prescriptions are being actually recommended, and ensuring that the physician actually agrees with the prescriptions that it makes a recommendation of. And in the end, we try to achieve something that the overall incredible vision of how autonomous vehicles are going to save lives. Our idea is to actually reduce the medical error on clinical floors, but in addition to that, to be able to improve the physician workflow by bringing the actionable knowledge from experience that have already been passed and making them reusable over and over again and bringing it to the forefront of physicians so that they don't have to search for all of the data that they need. They don't have to search for the recommendations and the order entry that they need, but that the recommendation from the system that is offered by the algorithm is exactly what they pick, and thereby reducing the resistance that we actually see currently in private practice and a lot of the practices that are actually out here. And in addition to that, reinforcement learning algorithm allows us to optimize for pretty much anything. So for things that we really don't know about, for side effects that we don't know about, we can actually penalize those side effects, penalize the medical errors, and exploit medical errors as a way to further drive and improve the improvement of our algorithms and our platform. And with that, and with the Ray technology and being able to actually work at pretty much any scale of computers using any number of clusters, even from Google, we are actually able to optimize for a lot of the same primary endpoints that clinical research is potentially using, such as survival, safety, and clinical improvement. And clinical improvement is one unique aspect in that reinforcement learning does, which Dr. Ritten Sutton has written significantly about, is that we don't necessarily have to wait for the final outcome, the primary outcome, to begin to improve our models. All we have to do is look at the interval change and the interval improvement, and the algorithms will actually improve on their own. One of the greatest benefits and advantage of reinforcement learning, as we will see in one of our pilots here today, and at the same time penalize for the things that we look at, such as readmission rates and heart failure readmissions, which we can actually do here and allow the algorithm to try to actually improve upon that and supervised by the physician. So with that concept and with the coding that went into that, we were ready to do our first pilot. And it was at exactly the same time that a lot of the colleagues from our floors were starting to get information from India that there was a rising surge in new variants of COVID-19 and a healthcare system that was on the verge. And we decided to actually, and they asked us whether our algorithms would help it and help them in two major ways. One was, can we actually prove out some of the treatments that we were using on the ground to see if it actually works? And the second one is whether we can actually collect data and help the physicians on the ground do better follow-up on their patients. It turns out that they had a lot of different issues in terms of resources that they were bumping into with the second COVID surge, which is they had two variants that have relatively little known treatment options. And the second is that the dynamics were not very well known, and the speed and the progression of the disease in and of itself was still relatively new at the time. They had issues on the ground, including that they had resource issues, finite hospital beds. 4 out of 5 patients that needed hospitalizations were actually sent home with prescriptions for oxygen and allowed to actually search their community in Delhi to find their own oxygen tanks, which was not easy to find. They were given prescriptions for blood pressure monitors and heart rate monitors like pulse ox monitors and steroid therapy so that they would do their own vital signs and perform their own treatment. Some of the side effects actually included longer-term use of steroids than actually initially intended by the primary physicians. And that led to several major side effects, sometimes devastating side effects like mucormycosis, a black fungal type infections that affected the face and caused blindness. Obviously, if they're not inside the hospital, the amount of data that they were collecting on follow-up was relatively limited and quite non-existent, in fact. So we provided the platform and the UI UX interface that actually allowed them to enter data and gave us an advantage in terms of how we would scale this to the interaction of patients. And obviously, if there was no data for follow-up on the patients that were in the community, the efficacy of treatments that were going on were relatively unknown. And they were dealing with lots and lots of different treatment options and a lot of different varieties of different prescriptions. In addition to that, patients in the community are often not known whether they actually progress into sepsis. This is a condition that actually progresses relatively rapidly, and we wanted physicians to be able to reach those patients on a drop of a dime. And we will show our platform for that. The number of patients that were actually getting infections were also rising at a rapid level and potentially will exceed the United States as one of the expected numbers that go up. Very similarly, we've actually created our own dashboard, a dashboard that actually monitors all of the patients of a particular physician and watches their risk level. Because COVID-19 was not being treated or was not in existence of the nomenclature during the time the data set was created, we had to create a new model. Our physicians wanted a way to actually assess the risk of the patient, not necessarily just the diagnosis. This allowed physicians on the ground to be able to reach out and intervene on patients of the highest risk. So we actually gathered together lots of physicians that were motivated to do this, and that took in the typical format of medical data that came in, which included the notes of the patients, the vital signs, labs, COVID testing, PCR, and vaccination history, and also the review of systems. and allowed the physicians to label them relatively quickly as mild, moderate to high risk for any particular problems. With that, we found that physicians were able to label hundreds of patients in a matter of a day, thereby offloading the physicians on the ground over in India where their offices were being inundated by phone calls. This actually changes the paradigm of work and eases the practice of medicine, even in a very sort of dire type situation. As we trained this in a supervised learning model, the physicians were able to label 10 to 20% of the data, but have the machine then monitor the remainder of the 100% of the patients that are out there and allow the physicians to be able to click on the high risk category and see which of the patients are actually deteriorating. Once we derived the disease state, it was time to actually put that in a reinforcement learning external environment. Because reinforcement learning required looking at the serial and sequential progression of disease, we concatenated the disease states day after day together in a linear sequence. That allowed us to be able to associate that again in a new supervised learning model to different treatment types, such as remdesivir, convalescent plasma, dexamethasone, and aspirin, and multiple medications, including probably close to a list of 20 different medications that were being used in India at the time, including non-prescription interventions, such as YouTube videos to allow patients to learn how to use their nebulizer treatments properly, COVID-19 exercises and lung exercises, very similar to pulmonary rehab, and also how to actually even measure their blood pressures and heart rate properly. Once we designed and trained the supervised learning models, we were then able to put it into the RLlib external API, in which the recommendations that were coming out of the supervised learning models were then taken over by the RLlib API, and in which case it can actually receive the rewards from the environment. And with that, we incentivize the algorithms for clinical improvement in the vital signs, getting them away from low oxygen scores and tachycardic and sepsis criteria, and obviously and survival and avoidance of hospitalization, and penalizing things that we did not yet know about, such as things like stroke and the reason for mucormycosis. And together with all of that, we learned a new way of actually being able to launch a web application into the environment, in an environment that potentially the algorithm has never touched before. We were able to engage patients in a completely different way, where in a 14-day window, we were able to upload vital signs and different symptoms from different systems of the patient nearly on a twice-a-day basis, allowing the algorithms to see with higher resolution and allowing the physicians to, even though the physicians were not there recording the vital signs every single moment, the amount of data was there, allowing the physicians to react to those individuals that require immediate attention. From a physician's perspective, we created a UI/UX interface that really allowed the physician to work on the problem itself, labeling the data for the supervised learning models, and monitoring patients at a very, very higher level, allowing a larger number of patients to be seen where waiting lists could potentially be tackled immediately, and allowing the physicians on the ground to react to the patients that require immediate and urgent attention. We had actually MD, PhD physicians that took our data and continuously associated them and learned which treatments were actually doing better than the other, and allowing our model, our reinforcement learning model, to be compared to the actual treatment and the results that they were getting from people on the ground. And at the heart of the entire project, we had our AI model that was developed within RLlib that allowed recommendations to come through from the supervised learning models. Remember those reactions and remember how the actions that was prescribed from the digital world affected the actual real world environment of patients and physicians, and actually the physiology and even a pathophysiology of a particular disease state that has not yet necessarily been completely flushed out. And we did that with even unlabeled data, right? Where reinforcement learning was actually able to learn from a rewards-like type system, as opposed to collecting hard data in terms of how these patients actually were done, and was actually learning it in real time and allowing the algorithms to back propagate those errors and continuously iterating through different policies, and allowing the physicians that were using the algorithm to pick the best policy that worked well for them. We tracked several different markers, and the results are still to come, but we were able to prescribe multiple medications per day. We were able to track how the AI actions were being accepted by the physicians and watch the mean rewards over time, learning how the algorithms was improving and learning whether the algorithms were not improving. Physicians on the ground have been able to shave off 5 minutes per encounter from multiple different aspects of the project. One, from the labeling aspect of the physicians being done, and the second as how the machine learning algorithms were able to categorize their patients in the community relatively immediately and give back time to the physicians. We believe that systems like this, where incredible turmoil and chaos can potentially occur, where even at the physician level, where the physicians are doing the best that they possibly can to treat patients, there is a tremendous advantage of having a system in the background that organize the data, that learn from the data, and potentially make recommendations that would potentially do better than what the physicians would do, because the efficacy of treatment at that particular time is not quite available. And a system of reinforcement learning does something very unique to the data. It actually bootstraps the data and improves the quality of data over time. The second aspect of it is that it improves the patients within that system over time, because as it improves the diagnosis and improves the treatment, the data that is coming into the system allows the algorithms themselves to pick the correct patients to treat over time. And with that, we're excited to actually open our projects to any type of developers that want to join us to be able to help with this particular plight, whether you're a data scientist or physicians. We would love for you guys to join us to see what we're developing and share in the fun and the excitement of doing that. Again, we'd like to thank Peter for his time joining with us over from the Mayo Clinic. Thank you very much.